Hi, everyone. Good afternoon. Thank you so much for joining us from wherever you're joining us today. It is a pleasure to be here today with a very amazing personality to talk about something that's very important to every one of us. Doesn't matter the color of your skin, everybody needs to hear what we have to say today. So, today I'll be talking about, or we will be talking about kidney health, transplant, and donation. And with me to do justice to this topic is an amazing transplant doctor, a hero in his field. I'd like to give you some time to introduce yourself because I don't think I will do you justice. Go ahead, sir.
Hello, everyone. My name is Anthony Watkins. I'm the surgical director of the kidney and pancreas program at Tampa General Hospital here in Tampa, Florida. I've been a transplant surgeon now for 14 years, and one of my missions within the field of transplantation is to provide equitable access to all patients. So today we're going to have an excellent dialogue and really go over some of the key elements that affect patients of color with kidney disease.
Did I say hero? Okay, now you see why. All right, let's get into it, sir. So I know you're a transplant doctor doing all this amazing work, with transplant. But when you think about kidney health and transplant donations, what would you say the role of primary care physicians and nephrologists is in ensuring that patients are referred to transplant on time for evaluation?
Yes, and I'm glad you started with that question because what I often emphasize to patients and to people is that while I'm a transplant surgeon and I enjoy transplanting people, one of the real initiatives and important elements of care is prevention, right? So, what are the steps that we can take within the community to provide timely diagnosis of diseases that can affect the kidney? To educate patients on lifestyle modifications and healthy diets, things that can prevent the development of these disease processes. And then, in regards to your question, it's really important for patients to have a primary care doctor that they're seeing every year, so that if they do develop, a disease that leads to kidney disease, such as high blood pressure or diabetes, it can be managed appropriately. In regards to the nephrologists are really the primary gatekeepers
Okay.
when it comes to referrals for transplant centers. Once a patient has been identified as having chronic kidney disease, they're typically referred to a nephrologist for specialized care. And it's really the onus of that nephrologist to timely refer patients to transplant centers when they meet the criteria for that, which is when their kidney function is or GFR is at 20 or below. So the
Okay.
nephrologists really play a vital role in this process because they play, the gatekeeper, so to speak, in regards to referral to the transplant center.
Okay. Okay. All right. So I want us to touch on the disparities that exist. I know you talked about the role of primary care doctors. Everyone should be seeing a doctor, and yes, we know that a lot of there are some people of color who may not be seen, who may not have nephrologists but have primary care doctors. So they are trying to do the right thing, right? And they're seeing that. But why does it seem like Black and Hispanic patients, especially, have longer wait times when it comes to transplants? What are some systemic changes that are needed to close the gaps that still exist when it comes to transplant for people of color, especially Black and Hispanic people?
Yeah, so there's multiple issues that play a role into why their waiting times tend to be longer. First, as we were just discussing in regards to the referral process, there's often delays in that regard, meaning that for a multitude of reasons, some of these patients might be candidates for transplant. However, they have not been educated and informed or referred to a transplant center, which can contribute to the delay from in that regard. Another issue is some of these patients actually do receive the appropriate education and information in regards to referral, but they're reluctant to go to a transplant center due to a variety of reasons, which include mistrust, in the healthcare system, and also unfortunately, these patients tend to be the ones who tolerate dialysis better than other ethnic groups, meaning while they're on dialysis and have to go several times a week, for extended periods of time, they feel relatively okay. They're not feeling that the dialysis is really taking a toll on their body. So for some, there's a delay in pursuing transplant because they feel that dialysis is suitable for the for long term management. But as we know, if you have end stage renal disease, transplant is the gold standard of treatment. It improves your survival, improves your quality of life. And it mitigates some of the negative impacts that dialysis has on patients' overall health, such as your increased risk of cardiovascular mortality. So I think there's, in essence, there's a combination of factors that lead to extended waiting times for these patients, and they're related to the referral, related to some internal issues, and then there's issues also related to some delays or challenges that occur once they're referred to the transplant centers. Oftentimes, there's some social support challenges that transplant centers recognize and have to kind of tease out prior to listing that patient. So those are some of the main bullet points. And I'd also finally add, so we make sure we have a very comprehensive conversation. And, these patients tend to have blood type B, all right, and blood type B tends to have a longer waiting time on the list because obviously you need more donors who look like you in order to increase the compatibility pool. So that's the last relevant factor that I think should be mentioned as well. And that obviously is a plug for the audience to ensure that, make sure that people sign up to be organ donors because it gives an opportunity, to help those in need.
Okay. So other than um, re- what you just said about having people sign up to be organ donors, are there some changes that could address some of these things that you listed as the reasons why people of color mostly have longer wait times?
Yeah, I think there's a lot of strategies and opportunities to improve access to transplant for people of color. Obviously, mo- education is one of the most powerful mechanisms in regards to really dispelling some of the myths in regards to organ donation, some of the myths that are misinformation in regards to candidacy for transplant, right? There's some people, even providers within the community, that think that there's a certain age cutoff or, certain comorbidities such as heart disease that impact a patient's candidacy for transplant. These are items that need to be discussed. There are also plenty of opportunities for policy changes, right, that can decrease some of these barriers, such as addressing, public health policies that can, mitigate some of the challenges with social determinants of health. There's been policies within transplant allocation, which is designed to provide more equitable access for these patients and addressing some of the other historical systematic barriers, such as EGFR calculations that have contributed to these challenges. So it's really a multitude of several initiatives that that we all have to kind of put our heads together and work together to mitigate these issues.
Thank you so much. Thank you so much. So that brings me to my next question. Let's talk about the transplant process itself, and the barriers that exist. Walk
Yeah.
us through the major steps in the transplant journey, from
Okay.
referral to follow up, and where patients would you typically face the biggest obstacles.
Yeah, so if you look at the transplant process, it's very complicated. I usually, when I'm giving talks, put up a figure that illustrate how complex that is and how a breakdown at each step can lead to attrition from the process, i.e., a patient not making it to transplant and ending up on long-term dialysis. At the transplant center, level, some of the barriers are really along the lines of social support. That's probably the biggest hurdle because, once a patient is referred to a transplant center, what our job and goal is to make sure there's no medical contraindications to transplant, i.e., if there's a malignancy or a cancer that needs to be treated, because once you get a transplant, in order for that transplant to survive, you have to receive medication that suppresses your immune system. And suppressing your immune system, we have to ensure that there's no current cancers or infections that would then wreak havoc on a patient when their immune system is compromised. So we have to rule out disease processes such as these to ensure that immunosuppression can be safely administered. We also have to make sure their body's strong enough to undergo the operation, right? So we have to make sure their heart is, there's no significant heart disease, lung disease, etc., so that they can undergo the transplant safely and recover. Those are usually the easier parts because they're more objective in regards to, is there cancer? What's the health of the heart? The more subjective element is then we also want to ensure that these patients have someone to help them post-transplant, help them come to their visits to the hospital, to have their labs drawn, to help them around the house, to help make sure they're able to take all these new medications or that are required to protect this life-saving organ. And
Mhm.
that piece is a little subjective, right? Because there's a lot of challenges that individuals can have when it comes to social support. For example, the one social support you may have difficulty calling out for work on your days of appointment.
Mhm.
um, there's also, an element of subjectivity in regards to, what's required, because there's variability in regards to what one transplant center requires versus another. So one of the things that we did here in my program is we collaborated with Northwestern Medicine to create a program designed to mitigate some of these issues that I just discussed for patients who are at high risk for not making it to the waiting list, due to some of those reasons I just outlined. And the goal of this program is to provide a set of providers with a shared experience, so that we can mitigate some of the implicit biases that might play a role in subjectivity in regards to candidacy, and also provide additional resources to help the patients get all the testing done to get them cleared, to make sure we can help facilitate, whatever unique needs they might have. And culturally, there's often elements of that kind of come into play. And so when you have individuals with the shared experience, they can mitigate some of the mistrust that I've mentioned before,
Mhm.
and connect with the patients more effectively to get them listed. Because once a patient gets, cleared and put on a transplant waiting list, the next issue is, the average waiting time is anywhere between 3 to 5 years for a transplant. So now we have to ensure that that patient is staying as healthy as that they can during this waiting time. And then they have to come and see us and have tests that go out of date, have them reperformed, to make sure everything is ready to go once they get called for transplant.
Interesting. Okay. Now, let's talk about multi-listing. I
Right.
was one of those who recently learned about this, but a lot of people are not aware that you can be listed at more than one transplant center to reduce wait times. Are there ways that we can be publicizing this better so that patients take advantage of this?
Yeah, and at first, it's important to recognize, well, why would you need to get listed in multiple transplant centers? Why can't I just get listed at the closest transplant center and be okay? Well, the problem is there's geographical disparities in the waiting time for a transplant. So depending on where you live in the United States, unfortunately, that will dictate your access to transplant. If you live in New York City, for example, you're going to have a much longer waiting time than if you live close to Toledo, Ohio, which has just, some of the shortest waiting times in the country. So the goal or the purpose of multi-listing is to increase your access to transplant by getting first, obviously, listed or ideally listed locally where that's close to home, but then also identifying those other transplant centers in other parts of the country that ideally have shorter waiting times, but also you have some local support there, i.e., family or friends, right? Because the way this works is if if you are able to get listed at this other transplant center, the reality is they'll have when they call you and say that they have an organ available for you, you have to then get on a plane or get in a car to get to that transplant center, which then brings in another important factor,
Yeah.
right? You need to have the resources, the means to be able to not only go to that other transplant center to get listed, right? But also to have the resources and ability to hop on a plane at the last minute, right, to get there to receive that life-saving organ. So, it is a strategy that is very helpful to mitigate the geographical disparities that exist, but unfortunately, it's only achievable for a small percentage of patients because of the financial and resource constraints that it demands. One example, high profile example to use to illustrate how this works is as Steve Jobs, needed a liver transplant, and Steve Jobs lived in California, but he multi-listed for a liver transplant. So when he actually got transplanted, his transplant was performed in Memphis, Tennessee. So he hopped on his private plane and flew to Memphis to get that transplant. And so that is an example or a high profile example of that in action. And the last statistic that I saw in relationship to this, it estimated that about 15 to 20% of people who are waiting for a transplant pursue multi-listing. The only other main important piece to mention is that there can be some insurance barriers to this
Right.
because not all insurances cover this. But for those insurance, for those patients who have the appropriate insurance and the resources to do this, it is a very attractive option, to kind of increase your access to transplant.
But how does one find know about this? For instance, I don't. A lot of people are not aware of this, right? As much as it's expensive, you would think that okay, if people can find a way around it, it would be nice for them to know that this is an option. So, are there ways that we can publicize this more? That there,
Yeah, and I know that when I worked in New York City, this was something that we would educate our patients on because we recognized that we had longer waiting times in other parts of
yeah,
the country.
okay,
So that means that one, viable mechanism is the transplant center. When I was in New York, as I said, we would tell patients often, hey, should go to Florida to get listed or
okay,
or other parts of the country. Whereas, truthfully, where I am now, my kidney transplant program is one of the top two busiest programs in the country. So the need for a patient in my geographical area that I serve to get multi-listed is not as significant as someone who might live in California, as an example. So, first and foremost, it's not something that everyone needs. It depends on where you live,
okay.
and second, and again, I think the main onus is on the transplant center to recognize that reality and provide their patients with this information.
Okay, fair enough. You talked a little bit about the insurance piece, part of this with regards to eligibility. And I'm wondering, are there other eligibility barriers that patients could be facing that you could highlight and ways that that patients can be supported through them?
In regards to the multi-listing,
Not just the multi-listing,
um,
like
um,
generally speaking, like with regards to the transplant process, what
uh,
are some other eligibility barriers that could
Yeah,
be?
well, I think another important piece to highlight is that there's two types of transplants. It's either transplants that come from a deceased donor, transplant that comes from a living donor. Living donation transplant confers the best outcomes for several reasons. Number one, kidneys from people that are alive or healthier. They tend to last longer after transplantation and they tend to work immediately. So, you know, and kidneys do not last forever, for example. So a transplant has something called graft survival, which basically gives a statistic in regards to the average amount of time after transplant that patient should expect that kidney to still function, appropriately. So when you look at living donor kidneys versus deceased donor kidneys, for example, a deceased donor kidney is estimated to last roughly 10 to 12 years for all comers, whereas the living donor kidneys are estimated to last much longer, 15 plus years, as an example. So having a living donor, i.e., a friend, family member, or stranger donate a kidney gives you a better quality kidney, but also prevents you from the need to get on a waiting list and wait for several years,
Yep.
right? Because once you're cleared and your donor is cleared medically to proceed with transplant, then you can get that done in a timely fashion. You're typically talking on a magnitude of months versus years, right? So, this is why there's a big push for living donation, because this is an infinite pool of donors. And we really have had stagnant living donor rates in the United States over the past several years. So there's, while deceased donation and deceased donor transplants are increasing, unfortunately, our living donor volumes are relatively stagnant. So there's still a significant need for us to augment that type of transplant. And it, unfortunately tends to, have lower rates within, Black and Hispanic communities. So these patients who tend to have a higher rate of end-stage renal disease have a higher need for transplant, have the lowest access to transplant due to some of the barriers that we discussed, also tend to have the lowest rate of living donation.
Okay. Thank you. Thank you for highlighting that, because hearing you talk about living donors, yeah, living donor kidneys, actually leads me to my next point about myths. Um, what are the biggest misconceptions that people have, especially people of color, when it comes to living donations? You talked about the low rates in the black and brown communities. What are some of the biggest misconceptions you've heard about living donors?
Right. Well, the biggest myth about organ donation in general
Okay.
is the classic, well, if I'm an organ donor and something happens to me and I go to the hospital and needing, acute critical care, and they realize I'm a donor, they're not going to try to save my life because they want to procure my organs. So that's the biggest myth that, I've spent a decent amount of time trying to dispel. It's interesting because, unless you're in the field of medicine, you don't realize that, someone comes in critically ill, our goal is and focus is on saving that life.
Yeah.
We're not going to say, hey, wait a minute, let's find the driver's license and let's see if they're an organ donor. That doesn't happen. But I mean, truthfully, it's a very significant myth, and I used to think that it just really um, existed within individuals maybe with low socioeconomic status and low health literacy, but I've even heard that from well-educated individuals as well. So that's one of the biggest myths. I think another, the other myth, in general, or misunderstanding is that if you donate a kidney, you're not going to live as long, or there's a big incision to do it, and you're going to be in the hospital for a long period of time. So, from a living donor perspective, we do it minimally invasive. Means we use small incisions. Patients are in the hospital for 1 to 2 days. They're back to work usually by roughly in 4 weeks. And studies have shown that once you've been medically cleared and healthy enough to donate a kidney, there's no decreased survival. There's no increased risk of kidney failure with one kidney. I think depending on your religious, belief, I think God, made this system redundant in order for us to do what we do now in regards to organ transplant. So I think those are two of the biggest myths and misconceptions that provide a huge hurdle for some patients' willingness to sign up to be an organ donor.
Okay. Thank you. That's deep education, things to consider, so that people
Yes,
like
yes.
myself hopefully can consider being organ donors. Thank you for clearing those up. Talk to us about the paired exchange donor chains, like the NEAD chains. How do
Mhm.
those work and why are they so powerful?
Yeah, so kidney paired or paired kidney exchange rather in general is a mechanism that we have um, primarily because typically if someone has a potential organ donor,
Hmm.
um, unfortunately roughly 30% of the time that patient might not be compatible with that donor. So in kidney transplant, if you need to have blood type compatibility, and then we also have to make sure there's no antibodies present that would prevent a kidney transplant. So what if, I have my significant other wants to donate to me, but we're incompatible. Instead of saying, oh, you know what, we can't do that transplant, you have to find someone else. We recognize that there's other patients around the country who are facing that same issue. And as I mentioned before, since living donation and living donor transplants confer the best outcomes, we want to ensure that we maximize that type of transplant. So the role of paired kidney exchange is now to take these incompatible pairs and put them in this registry, so then we can exchange kidneys across the country, providing individuals with compatible kidneys via their intended donor. So and there may be someone in Chicago that I'm more compatible with, and then there might be another pair in another state where my donor is more compatible with them. So we participate in various programs that facilitate this paired kidney exchange with the goal of still utilizing living donor kidneys, and therefore your donor is donating to you indirectly.
Okay, that is powerful, and I hope that more people will get to fit into that chain. Um, still talking about living donors and living donations, are there any form of supports or resources that exist for people who may be considering that option? So, if I was thinking, for instance, of joining the registry and donating a kidney, are there resources that are available to me because I would need time off to recover from work?
Right.
So, are there those kinds of support for the donors?
Yeah, that's a very great question. First and foremost, it's important to highlight that the recipient's medical insurance covers the donor's workup. So the donor is not coming out of pocket for their medical evaluation. But you also touched upon, another important aspect of what about their time off from work and travel to the hospitals and things of that nature. So um, there are various um, there are various resources that are available to donors to reimburse them for cost that are used, out-of-pocket expenses that are used to facilitate the transplant process. And there's some laws, both there's some policies, laws that are being devised to optimize the candidacy or optimize this reimbursement of these expenses, because to be transparent, they're not there's still opportunities to make it where a patient does not come out of pocket whatsoever, and as it in current state, their lost wages aren't reimbursed, right? So, you know, myself and others are working with Congress and other individuals to revise and create strategies to ensure that ideally a donor can donate a kidney and not come out of pocket in any shape, form, or fashion. And so that, so I think, to kind of review, the recipient's insurance covers the workup. And then the transplant center and other organizations have mechanisms to reimburse the donors for out-of-pocket expenses that are, accrued during this process.
Okay, amazing, amazing. And kudos to you and all those who are working with you in that, in making sure that we find ways to reimburse, to cover this and continue to do this work. Please, we would love to jump on that train with you. So if there's anything
Mhm.
you think that we could do with NMQF, please let us know.
Okay.
Thank you. So let's talk a little bit more about life after transplant. So we have this person, they've considered it, they've donated, they're now heroes doing this work and have helped somebody else leave. What does recovery look like for them as a donor, and what does it look like for the recipient?
Yeah, so for donor, as I mentioned before, typically they are in the hospital for 1 to 2 days tops. By, after the donation is performed, they're able to eat, they're walking around. Obviously, we're giving them medicine to control their pain. And at our center, 50% of people leave on postoperative day one, the remaining leave on postoperative day two. Um, they're back to work in 4 to 6 weeks. And as I mentioned, there's no decreased survival or increased risk of kidney disease with one kidney. So patients can donate a kidney with a short hospital stay, small incisions, and back to work in a short period of time.
Okay.
For the recipients, their stay tends to be a little bit longer, anywhere from roughly 3 to 5 days, because their incision tends to be bigger. And we have to start that specialized medication to suppress the immune system to allow their body to accept the organ. So they tend to need a little bit more time to fine tune these medications, and to get additional care, a little bit more additional care than the donor would. But you have to remember, it's not just the kidney failure that they have. They typically have other comorbidities as well. So they're not as healthy as the donor. But again, they are they're back to work, if they do return to work, a little bit longer, because after a kidney transplant, patients risk of rejection is the highest the first 3 months after
Okay.
transplant. So this period of time is a little touch and go in regards to people being around a lot of potential contacts who are sick. There's a significant amount of follow-up that's done, immediately after transplant. When they're discharged home, they're coming, to the hospital roughly twice a week to get labs and get follow up. So because of this intense follow up and lab checks, their ability to kind of return to the
Work.
normal, way of living, yeah, is a little delayed, but typically are usually around 3 months. They have the ability to kind of fully, reintegrate, so to speak, into society and work and travel and do things of that nature.
Okay. That's not bad. You
No,
mentioned
not at all.
anti-rejection. Yeah, you mentioned anti-rejection medications. How
Right.
does these, or you talked about anti-rejection or rejection being highest in the first 3 months.
Right.
So for anti-rejection medications, how do they impact the person's quality of life? Do they help that much what's existing currently, and are there new advances in that area?
Yeah, so the way they help is they suppress the patient's immune system, because our bodies are trained to reject foreign organs, right? So if we just took a kidney out of one person and put it in another person, then your body would attack that because it's not self, right? So we have to trick the body into to thinking that that organ is not harmful. So we do that by giving medication that suppresses the immune system. Now, this medicine is not 100% effective, right? People can still have rejection. So that's, we still have to monitor for signs of rejection by looking at blood work, looking at, urine output, et cetera, to ensure that's not happening. And then additionally, we have to be mindful that when a patient's immune system is suppressed, that then puts them at risk for infections, right? And then it also puts them at risk for certain cancers, usually skin cancer and a type of lymphoma, are the biggest side effects of that. So patients are advised to, keep distance from people from that are known to have sicknesses because your immune system can't ward that off as well. They're advised to minimize their exposure to sunlight, and then we do surveillance for other types of issues that can occur as a relationship to these medications. There's also every medication we give has side effects, right? So there are a number of side effects that patients can have, anywhere from mild GI complaints to, neurological tremors. But fortunately, these tend to only affect a small subset of patients, and even when they do, they tend to be mild. And we have strategies to address these issues by adjusting the frequency or dosage of the medication. So in general, patients are their quality of life is much better after transplant. Their energy levels are better because, the kidneys also produce a hormone that creates red blood cells. So
Yeah.
people with end-stage renal disease tend to have anemia. So, they have better blood counts. They're not going to dialysis 3 times a week or doing peritoneal dialysis, every night at home. And they don't have the dietary restrictions, as another example that are needed with dialysis. So people they feel better, they look better, and they live longer.
And they live longer, which is the goal.
Right.
Yes.
That's right.
Yes. Thank you. Thank you so much. So, how can we help? What policy changes would you say would have the biggest impact today? If this happened with regards to policy changes, it will make the biggest impact in increasing organ donation and transplant equity.
Well, I'll first say the biggest change, would actually be along the lines of preventative, right? So if we can address this social determinants of health, where so that where people live is a healthier environment, they have access to healthy food, better high quality insurance, their health literacy is significantly improved. I think that's a real important area because then you can minimize the development of high blood pressure and diabetes, which are
Amen.
two of the most common causes of kidney failure. And if you look at the trend of the two over time, high blood pressure is actually declining, whereas diabetes is increasing at an alarming rate. So, really, making sure individuals understand that eating healthy, having an active lifestyle, seeing a physician every year. And again, where they live has the resources that are conducive to that, I think would probably be the biggest, or move the needle the most in
Okay.
regards to what we're talking about. From an access perspective to transplant, we really have to develop policies that break down the barriers at every step of the transplant process, right? So we need to, we need to have a mechanism that really provides a huge impetus for people to get referred to transplant centers in a timely fashion. For example, having education done in dialysis centers and the nephrologists, we as we move to what we call value-based care, right? Have it where these reimbursements are tied to referrals to transplant centers when appropriate. And then at the transplant center level, we need to make sure the transplant centers have the resources that are needed to get these patients effectively listed. We can't treat people like they're all the same. Some certain people need more resources, more time, in order to get them on the transplant waiting list. And unfortunately, when you have, certain constraints within your system, you might not be providing that time and effort for these patients that's needed. And then finally, as I mentioned before, we need more people to sign up to be organ donors, right? So we have more compatible organs available for these patients when they're listed for transplant. So for those, for example, with the blood type B, aren't, spending extended periods of times because of the lack of available compatible organs.
Very comprehensive. Thank you so much, Dr. Watkins.
Yeah.
All right, to address that last piece, what would you say is how can advocates, community leaders, you know, how can they encourage more people to sign up to be organ donors? What
Yeah, I think it takes
work?
it's all hands on. I think, for example, community partnerships between healthcare providers and faith leaders, as an example,
Yeah,
is a very powerful mechanism that allows us to meet patients where they live and where they are,
yeah,
and that kind of fosters trust. It provides the delivery of vital information in a safer environment. And I think so. I think that type of outreach is very essential in regards to educating the patients. And I've participated in church efforts. I've met with Divine Nine organizations. I mean, going to schools. I mean, there's a ton of opportunities to do the appropriate out radio, to do the outreach that really targets these communities so they're getting this really viable information in regards to organ donation. But it's all kind of intertwined, right? Because one of the issues are that, as I mentioned, these communities tend to have the highest incidence of high blood pressure and diabetes. So, the other issue is that some people who would like to be donors can't be donors because they have the same issue themselves. So it's all intertwined, so to speak, in regards to improving the overall health within these communities, given the appropriate information and education that stresses the importance of organ donation, and then really, emphasizing, all those mechanisms that I mentioned to make sure the people who are at need are getting listed and getting transplanted.
okay, all right. So much to think about, but I think we had a very good conversation today. In closing, what are the few things you'd like to call out, call to action for people who are listening? What's something you'd like them to walk away from this presentation with?
Yeah. Well, first, before I do that, I do want to mention some positive stuff, right? I think we discussed a lot of the challenges. I do want to say that there has there's been some strides in the right direction with organ allocation policies that have
Yeah,
improved the equity to access. Um, for example, historically there was a calculator that was used, a calculation, excuse me, that was used to estimate kidney function that had a race coefficient that artificially elevated the GFR, or the kidney function, for Black patients. Last January of 2024, a new policy went into place where that calculation is now race neutral. There's no coefficient. The old thinking was that Black people had more muscle mass than other ethnic groups, so they needed to have a coefficient to compensate for that. But we know that that's obviously not true, and but we recognize is that that was further providing a disadvantage in these patients' access to transplant, because it was artificially elevating their kidney function,
yeah.
delaying their candidacy for a transplant. So that was one major move in the right direction, and it's
Thank you for
really,
mentioning that.
yeah, it's really provided a powerful, a mechanism, or a change to correct something that was false and had been, long standing within the medical community. So I do want to
And that
highlight.
has kind of leveled the playing ground, if you will, right? Would you say?
Right, yeah, level the playing field, and it also, the good thing about this policy change was that it didn't just go into effect for patients moving forward, but it
Yeah,
also
back
was
then.
retroactive, right?
Yep.
So our transplant center, for example, we had over 200, 300 patients, Black patients on the list, and so we had to go through and recalculate their oldest kidney function, and we had an average of almost 2 years added to everyone's waiting time. One person had upwards to 8 years. So we were able to really get a lot of people transplanted quickly in response to this. So this was a huge step in the right direction.
Indeed.
Um, But the take home, one of the take home messages, I think, I like to say is health is the true wealth, right? Because no matter what, how much money you make, what walk of life you come from, once your health has fractured or has declined, your ability to contribute meaningfully to society or stay around for your family and loved ones is obviously diminished. So we as individuals and as a community have to take more responsibility for our own care. So we have to make sure we're taking the steps to see physicians. We have to make sure that we're educating ourselves on what does disease processes that we have and how they affect us. And we have to take more control of improving our health, watching what we eat, again, staying active with our lifestyle, because again that rate of diabetes is increasing significantly. And our diet and our lifestyle is playing a huge role in that. And then as we know, it's important to have the concerns with the healthcare system and address them, but don't remove yourself from that, because at the end of the day, unfortunately, you get hurt the most. You have to identify a doctor, have to have that. You need to have annual assessment of your care, because diseases such as high blood pressure can be affecting you and you don't even know it.
Yep.
It's the silent killer, as they say. So you might feel and look great, but have, high blood pressure that's affecting your heart, your kidneys, your blood vessels, etc. So really take ownership of your kit of your health, and sign up to be an organ donor so that you can also help others in need.
Thank you. Thank you so much. So much, so much. You've said so much so well. I'm really glad we had this conversation. And thank you so much for bringing up the point about the EFGR recalculation. I think that was um, something that a lot of people needed to hear, and reinforcing that there is hope and that there are progress is being made, even though
Yeah.
it looks like things may not be where they need to be right now. On my side, I just want to say kidneys do a lot more than people realize, and so can we. Early detection, like we've said, saves lives. Every step of the transplant journey can be navigated with with the right support. Living donation changes lives. Recovery is a journey, and policy plus community action makes the lasting most important change. And that everybody, whether you're a patient, whether you're a provider, whether you're an advocate, whether you're a community leader, your voice matters, and every one of us can make a difference. So, like Dr. Watkins said, please consider becoming a donor today. Thank you so much for your
Amen.
time.
All right.
Amen, indeed. Thank you so much for your time, Dr.
Thank you
Watkins,
for
and thank
having
you
me.
all for joining us today.
All right.
All
Bye
right.
bye.
Bye.